Hi, everyone. We're just going to give everyone a couple more minutes, maybe like another minute or two to kind of trickle in, but welcome to Elektra Health's very first Cheers with Peers Salon. I am just really excited that everyone here tonight is interested in menopause and sexual health and wants to learn and, wants to just kind of hang out with us. This is going to be really informal. We do have, quite a few folks joining us tonight. So everyone who comes in will just be muted. You are welcome to stay on camera. You do not have to. If there are questions, and I certainly hope that there are, please, feel free to put them in the chat. We are reserving time at the end of this discussion to answer questions, but we are going to try our hardest to keep it to 30 minutes because I know you guys are busy. You probably have all come off of a long day of work and, you're here and I love it. And I just want to be respectful of your time. So with that said, this is, we have a very special guest with us and we'll get to her, to Anna in just a minute, but I did just want to introduce myself for those of you guys who have not met me either virtually or in person. My name is Jackie Giannelli. I am Elektra Health's family nurse practitioner. I'm a certified menopause provider. And I also specialize in women's sexual health. So my, in-person clinical practice is dedicated exclusively to menopause and sexual health for women. So I feel super lucky to be able to work in that capacity. And I also have a very special guest with me tonight who also happens to be Elektra Health's founding physician. Anna Barbieri is a board certified OBGYN and integrative medicine specialist. So just like a 1-2 punch. She uses an individualized and holistic approach. She specializes in supporting patients as they navigate menopause through lifestyle changes, hormonal treatments, and non-hormonal treatments. She is an OBGYN from Mount Sinai in New York and did a special training, a special fellowship in integrative medicine out in Arizona. So I cannot think of a person more qualified to be chatting with me tonight about all things early perimenopause. We're going to start with that. Mostly because it's just, something I think people have the most difficulty with in clinical practice. And so I thought let's just get right to the heart of it. And Anna is really a specialist in using, a multimodal approach to help patients. And so we're lucky to have her at Elektra. We're lucky to have her here tonight. And hopefully you guys had a chance to read through the case study that went out. I will read it through a little bit. And I think we can potentially even, link to it in the chat in case folks want to pull it up as we go. But for those of you who are also not sure what Elektra Health is, Elektra Health is a digital women's health platform, a company dedicated to smashing the menopause taboo. And we do that through world-class education, evidence-based education, this being sort of one part of that educational outreach, community and clinical care. So we'll talk a little bit at the end about, how Elektra Health can partner with all the awesome clinicians that are on this call and those who will be listening to the recording after it's over, because we really, our job is to spread the word about menopause, educate, but also work with you guys. And so I'm excited to talk to you a little bit about that. So I think, yes, Elektra Health popped in the case discussion in the chat. If anyone needs to click on that, feel free to do so. But I think let's just get started. What do you think, Anna?
Let's do it. And Jackie, thank you so much for that intro too. That's a great intro, and welcome everybody. I really enjoy working with Jackie here, and I'm so glad to be in front of you all tonight. I'm really, really passionate about menopause. My sort of personal medical approach is really a combination of both conventional academic medicine, which is really my background, combined with really more holistic approaches that are also rooted in evidence. So certainly in my practice, I do use lifestyle medicine. I do on occasion use supplements, and of course we use hormone therapy and medications when needed too. So we're happy to be here and share some info with you and answer any questions.
Amazing. Okay, so I'll read through this case just so we can kind of refresh our memory. This is a patient that you guys obviously it's a made up patient, but this is a patient that I bet every single person on this call who takes care of patients has probably seen at one point or another. We did that on purpose. So this person's going to be 43 years old. She's coming to you basically because she didn't get the answers she wanted from her regular doctor. So you're a menopause specialist. She's coming to you for some answers. So she's got fatigue, sleep disturbance, weight gain, decreased libido, some breast tenderness, and worsening PMS right before her period, and maybe getting a little warm at sometimes as well. Periods are getting closer together. They're now 25 days apart, which is a change from her baseline, slightly heavier as well. And these symptoms started a couple of years ago, maybe gotten worse over the past 6 months. And that's when she asked for help. It's to the point where she's miserable. Like that week before her period, like she's a different person. She yells at everyone in her house. She's just not herself. And that's what she says too. I just don't feel like myself. Things that she has tried, intermittent fasting, low carb diet, high intensity training at the gym, some supplements, maybe some melatonin, maybe some Maca. Nothing's really moved the needle that much. She brought this up with her GYN, who pretty much said, sorry, this is what happens when you hit 40, and just said, maybe cut out the alcohol. And I know I hear of that all the time from my patients who've been to their doctors and said, sorry, this is what happens, right? Nothing's more frustrating than that. She's up to date with all of her routine care, right? Everything's been normal. Past medical history, she's got some baseline anxiety. She takes some Lexapro, it's well controlled. Some hyperlipidemia, no history of blood clots, DVTs, personal history of breast cancer, anything like that. She's had a couple of C-sections, some breast implants. And we talked about what supplements she's taking. I didn't mention this in the case study, but I'll throw it in now. For birth control, her husband has had a vasectomy, so she's not on any birth control herself. She drinks, a bit. She has a couple glasses of wine per night, sometimes more on weekends. She does it to cope. Her anxiety sometimes gets a little bit, spiky. And so she uses alcohol that way, but denies any smoking or other drug use. Does have a family history of breast cancer, sister and 2 aunts. She did do genetic testing, which was negative. Her vital signs are good. Her BMI is a little bit elevated at 27, but not too bad. She asked her GYN for blood work because she's like, what's going on with me? We need to check some labs. So we did these on purpose on day 21 of her cycle. Her FSH and LH are within normal limits. Her estradiol looks a little bit elevated at 384. Her total testosterone may be on the lower side at 18. Her blood sugar control is, approaching sort of meh territory. It's 5.7. Her vitamin D is a little low at 22. Her thyroid panel looks good. But like we mentioned earlier, her lipids are a little bit elevated. So her triglycerides are 170, her LDL is 120, HDL is 50. So her total cholesterol is 230. So when we see a patient like this, Anna, and we start to approach the problem of early perimenopause, I think we first sort of think about, okay, what is she telling us? Like we'll get to the labs in a minute, but what are her symptoms? And maybe even to back up a step, what's happening in early perimenopause for the people on this call? What are the hormones that are changing, and how might that be manifesting in the symptoms that she's telling us about?
So I'll be happy to talk about it, but I'm wondering if anybody has any ideas. And the reason we ask is that this is actually a sort of a different way of looking at the perimenopausal transition. And I will tell all of you that I have been that patient, this exact patient. I'm a few years ahead of her now, but I've been there. And as a person with those symptoms, and I have also been on the other side of that therapeutic relationship where some years ago, I also said, this is what happens. This is normal. Maybe here's a birth control pill script to normalize your hormones. And that's that. And the reason is that really in medicine, even in OBGYN residency programs, we really don't get a lot of menopause training at all. So I actually don't know how it is in NP programs, because I understand most of the audience is are nurse practitioners here. But really, we don't get much info or training. And so much of women's health is really devoted either to contraception or fertility or pregnancy care, or just well woman care, so screening exams, rather than menopause management. So this is why we thought we would present this case that is so common. These are people that certainly, we see every day pretty much. So anyway, I'm just curious, any thoughts from the audience about where this person is and what makes you think of perimenopause in her case? I apologize for that.
Decreasing estrogen,
What's that? I'm sorry.
like decreasing estradiol.
So her estradiol was actually 384. So this was pretty high. So yeah, so decreasing, somebody said decreasing progesterone, which is actually a really, and menses closer and heavier. And then somebody said perimenopause is estrogen dominant time. And I think that's certainly really true. So perimenopause can last for a long time. Some women go through the transition over the course of a decade. It's actually quite long. And it's the early part of it that can be quite prolonged. That early part is really marked by fluctuating estrogen levels, and that estrogen can be supraphysiologic. So sometimes it can reach levels that were higher than before. And by really progesterone secretion that starts to decline very rapidly. So I don't know if any of you have seen those graphs of hormones across perimenopause, but that early part of it is estrogen really going kind of crazy, sometimes oscillating way higher than it used to be before, going through some of those still cyclical changes, but in a much more kind of haphazard fashion. And then progesterone that gets released to a lesser degree. And that can lead to things like this shortening of a cycle. So often we see these women start having their periods, every 25, maybe 23, maybe then 27, back to 21, 22, really much shorter cycle, sometimes spotting before a period, which can also be due to low progesterone, sometimes heavier periods, right? Because estrogen, especially a lot of it, can build up that endometrial lining, and without a significant progesterone release, that's going to lead to heavier periods. So certainly, I would definitely agree with the people that put this down as a sort of as a pattern that consistent with early perimenopause there. The other thing is that this sort of low progesterone, high estrogen state is actually going to lead to more PMS and more breast tenderness. These are the women that are going to feel just kind of bloated and like they are retaining water, and their breasts are getting bigger, and they're really kind of starting to struggle with PMS. And I got to tell you, like, typically we used to think of PMS as a progesterone related condition, but in early perimenopause, it is often the reverse. The low progesterone, high estrogen leads to that. And then the only other thing I would add, and I apologize because I love menopause so much, I could talk about it literally for like a week straight. Somebody put here that perimenopause is an estrogen dominant time. So in conventional medicine, this phrase of estrogen dominance is actually not recognized, even though we all know that there are times where estrogen is actually dominant. So if you think of PCOS, for example, right? Somebody who's not ovulating, making estrogen, not making progesterone at all, or less frequently, that's an estrogen dominant state. And early perimenopause is that as well. So at Elektra and together, and because of our integrative training, we will use the phrase estrogen dominance, although we realize that in kind of academic medical circles, that's not going to be acceptable. But this is really what physiologically is going on. So whether we call it that or we call it early perimenopause, like we mean a state where you have fluctuating estrogen, maybe high estrogen, and then lower progesterone.
Yeah, that's all really helpful. And I think because there's a lot of confusion, I think, amongst the general public, but sometimes even amongst clinicians about like what, where people are getting their information from, what's like, what do we believe? What do we not believe? And I think like calling that out, is important because we're all talking about the same thing. We're just calling it a little bit differently.
Right.
Okay. So, that makes sense. Based on what she's telling us, we're like, okay, I think this is early perimenopause. Her blood work is pretty consistent. I mean, it was interesting about her lipids too, right? That there is sort of this metabolic component also to that. Hormones really aren't something that just are about sex hormones, right? That metabolism and the metabolic state of the body it all kind of, those puzzle pieces all sort of fit together. And so we do want to look at her holistically and also try to talk to her, maybe counsel her, and we'll get to that in a minute, right? About her metabolic health as something to optimize during this time that might also impact her sex hormones and the state of menopause that she's feeling currently. Would you agree?
I mean, I would definitely agree. I think those go hand in hand for so many women. The entry into perimenopause often sort of marks also the beginning of a metabolic change. We're seeing this in her lipid profile with those elevated triglycerides. I don't remember what her HDL was. I think it was pretty good still.
It was 50.
Yeah. Okay. We see that in her hemoglobin A1C, where she just met criteria for prediabetes. We see patients all the time that have these labs, and they are just told, don't worry. Today I saw a patient with a hemoglobin A1C of 6, whose doctor told her, great job, you don't have diabetes. Well, no, like, you're pre-diabetic and you just gained 30 pounds. Now it's the time to start working on it. So these are kind of small little red flags that we use to also assess cardiometabolic health, because it's basically a wake-up call for a lot of people that meet these criteria at this point. And as estrogen will go down, these metabolic parameters can get worse also.
Yeah, thank you.
And the only other thing I would say, like, just with her labs, we also have to remember, even though Jackie and I love perimenopause so much, sometimes something that looks like perimenopause is not perimenopause. So we certainly do want to take a look at the thyroid hormone. We do want to acknowledge that some people just have metabolic syndrome without starting to go through anything. We do want to say that sometimes we see people using certain supplements, for example, that may change their period. People that have insomnia or are depressed, not necessarily because of their reproductive hormones, but who have that as a background too.
Yeah. Like, looking at this holistically is super important, and it can get complicated. And I also think it's why it's challenging, right, for a lot of clinicians to spend the time in their 15 minutes they get with their patient, that they may see once a year, to really, dissect this out. And so, sometimes patients, need the practitioner who can step back and look at this holistically and think critically about what's going on with a wider lens. That tends to be the best for the patient. But when we're thinking about, okay, how do we help this patient? I think, our philosophy at Elektra and our philosophy, in our practices, is to sort of think in like layers of the onion. So there's the lifestyle, behavioral, maybe exercise and nutrition, the baseline things, because we know that I could give a patient all the hormones in the world, but if she's, eating terribly and, really super stressed out in her life and not, taking control of those things, those hormones they're just going to float through her bloodstream, and they're not going to like go or do anything purposeful for her, right? It really starts with good, basic, kind of boring sometimes, honestly, but really important fundamental lifestyle changes that a woman needs to also acknowledge and work on in tandem with some of the other, medical interventions that we provide. We also then, the next layer would probably be an integrative approach, which, Anna, you could talk about a little bit as well. What are some supplements, some easy things that somebody might try who really is like, I just don't want hormones, or maybe they can't have hormones. And they just want to start, like, dip their toe in the water a little bit and just try something that they think is simpler. So we can talk a little bit about that. And then, if all else fails, or if this person's just really like, just make me feel better faster, what would be like a conventional approach? What would, a NAMS doctor say? What would be something that, would have the most bang for your buck, and why? So if you would like not mind diving into some of that, or if anybody here has any ideas or things they want to share that they think, would be good places to start for this patient, go ahead and put it in the chat. We can talk that way. But other than that, I think I'd love to hear from Anna about what she thinks we would do next.
Sure. I would love to see some answers in the chat too. Like, I always love to see what people think and also learn from other people. So the way I think of these things, I think Jackie covered some of the lifestyle things. And I think, unfortunately, we probably won't have the time to get into the nitty gritty of things like mind body, approaches, or the particular nutritional approaches. The next step is usually the use of non-medications, meaning certain supplements or herbs, and the rate of usage of vitamins and supplements by women in midlife is pretty staggering. I think the last statistic I read was that over 50% of women use something. They they tend to use it to self-treat. Many of them won't tell us, their doctors and care providers, about it, because so many women are afraid that we're going to judge them for it. They assume we don't know much about it, and they don't want to admit to using them. But lots of our patients are using these things. The problem is that, and I see that's, all right, I see some great answers here already. The problem with supplements is that there are just so many supplements that are marketed for menopause or menstrual health, and they will have so many different things in them that it's sometimes hard to make heads and tails of them. And also that the problem is that things that may work for later perimenopause, when we're really dealing with estrogen insufficiency or estrogen deficiency, or the typical menopause symptoms like hot flashes and night sweats, are really not going to be very appropriate for this patient, because she's in a different hormonal state. And that's why it's so important for us to be able to assess where someone is along the transition and really tailor those recommendations to them. So certainly, from sleep, starting with very simple things like melatonin and magnesium, knowing the types of magnesium that are helpful, like, for example, magnesium glycinate will not have as many effects on one's GI system, to supplements that are really aimed at kind of making that estrogen progesterone balance a little bit more balanced. So if these are women that are in this estrogen dominant state, what can we do for them to help them metabolize all that estrogen? We certainly use the suggestions of including more fiber in the diet, including cruciferous vegetables in the diet. There's also a supplement called DIM, D-I-M, or 3-IC, that will help metabolize estrogen. You do have to be somewhat careful with it, because it can really drop someone's estrogen level sometimes. So sometimes we see people kind of overshoot and got hot flashes from it, but it can be quite effective. There unfortunately are not a lot of studies on it. Sometimes we have quite a bit of great literature on certain things, like melatonin, like magnesium, like something called ashwagandha for sleep, which is really an adrenal adaptogen. We didn't even get into cortisol here, but that's a whole other aspect of perimenopause too. And sometimes we just don't have the studies that would be, randomized and prospective. But certainly DIM has some good preclinical studies and some clinical studies, especially in the breast cancer population. So we can use that supplement. Vitex or chasteberry is the other end of that. That's a supplement that is sometimes used to increase progesterone production. It is not going to make you go from a progesterone of 0 to a progesterone of 22. It has a much milder effect, but on a supplement side, sort of a combo of DIM and Vitex can be used. On a more medical side, somebody did put this in, micronized progesterone. So yes, we use it sequentially. This person does not need contraception. So we have to be mindful of the fact that people in women who do need contraception, sequential micronized progesterone in the secretory phase, we usually start at day 14, continue through day 25. That can be helpful. It will not provide contraception for them. But yes, it can be helpful. And then finally, we have on a hormonal sort of scale there, we do have the more coarse tools of something like an oral combined contraceptive or combined contraception that is going to be of a sufficient dose to really suppress FSH and LH, and that will suppress one's endogenous hormonal production. So that sort of is aimed at kind of quieting down the system. And another good option could be a progesterone or progestin only pill. I don't know if any of you have a lot of clinical experience with Slind. Slind's ingredient is drospirenone. It's the same thing that's in like Yaz and Yasmin and now Nextelus. But Slind has drospirenone in it only, and because drospirenone has somewhat of a diuretic effect, this can work for well for these women as well, especially for the ones that need contraception too.
Yeah.
What else?
Well, there's a couple questions I thought were worth, asking about. So, and, Rebecca's saying, talking about alcohol is hard, and it really is because it's so socially acceptable, but it's really tough for women in perimenopause to have alcohol. Those two things just don't go together. And so how do we talk to patients about that in a way that doesn't feel, like you're wagging a finger at them or that you're being hypocritical? It's a good question.
Yeah, that's a great question. I will tell you, I mean, I literally had this conversation, I think earlier today, and basically said that, look, it's just, we know that not drinking alcohol in the long term is probably better for us, but so many of us use it, and it's not easy not to use it. And certainly for me, whenever I have my glass of wine at night, it's a choice because I know that if I have it, I will wake up 5 hours later, sometimes with anxiety, sometimes with palpitations. And I know that. So I have to pause and make myself make that choice, knowing what the consequences are. But I'm right there with you. I think that's a very, very common tool. And especially since the pandemic, we know that the rates of drinking have gone up quite a bit. So I think just being honest and like admitting to our own struggles with those decisions is the way to go. And the other way, and I have used this tool with some women also, is just really kind of challenging yourself to maybe 3 or 4 days without it. And often when we can compare sort of our sleep after a night of not drinking, or our thinking or cognitive function the day after not drinking, that's going to be, for some women, that's going to be enough of a positive reinforcement to really decrease their intake.
I also usually, put it in context because I think there's lots of women, as I'm sure everyone here, has experienced, that are just terrified of hormones, right? Hormones are going to give me breast cancer, but yet they're drinking 2 glasses of wine a night. And we know that the risk for breast cancer goes way up when you drink more than what's considered a moderate amount, which is right? Like 1 alcoholic beverage a night. And I would say there's lots of women out there who are doing way more than that. And yet they're terrified of breast cancer. So I think reframing the risks, versus the benefits of, a glass of wine at night, might just put a little bug in their ear too. And again, that's objective. That's not you judging them. That's just what the data says. And I think leading with that is always like a really, you're just giving the patient information and they can make their decisions based on that.
Yeah.
Yeah.
Someone asked in the chat about Bonafide. So I don't know if all of you are familiar with this company. Hello Bonafide is a company that's put out a sort of a line of menopause related supplements. They do have 2 products that are aimed. One is really aimed at hot flashes and night sweats. That's Relizen. The other one is Serenol, and that's aimed more at sort of PMS and PMDD, although I will tell you that for real PMDD, I wouldn't treat it with a supplement. I think we need heavier, stronger things for that. For, this type of patient, Serenol would be more appropriate for her because it has more of almost like an SSRI action. And she's not really suffering from a lot of vasomotor symptoms when Relizen would be appropriate. The only thing that would make me somewhat hesitate is that Serenol has royal jelly in it, which can have an estrogenic component. And she's already full of estrogen as we see it. So I probably would not choose that product for her from the line.
Yeah. I think she's also on Lexapro too. So I'm not sure.
Right.
That,
yeah.
the Serenol would be, but as a general, for somebody who's not, I do find that Serenol can be helpful as a mood stabilizer, especially for that week before your period.
And that's a good point. I forgot she was on it. Like we also don't use Serenol in addition to an SSRI already, just because one, it's sort of doing the same thing, and I don't want to worry about serotonin syndrome in any way. So I don't think that would be my top choice here.
Yeah. I think these were all, we covered a lot of ground and I'm sure that there are questions. Let's see, somebody asked, and we're not going to get to all of these, but we can talk about how we can answer them. So how would you change your care of this patient if she was also complaining of lower libido, which she did, by the way? I feel that is a common co-complaint. And as a person who basically hears this complaint on a daily basis from my clinical practice, I think it's, we looked at her testosterone. I do think it's on the lower side. And we know that testosterone is a hormone of desire, but you also have to look at this in the context of the fact that she's experiencing a lot of other things that can get in the way of her libido. So I would first probably try to correct some of those things. However, I would say when thinking about what to give her, what I do see often, and you are sort of sacrificing libido when you put someone on a combined oral contraceptive, because you're going to shut down a lot of their testosterone production by it's not only suppressing the ovaries, but also raising a blood protein called sex hormone binding globulin. When you take an oral estrogen, that raises SHBG, which I like to think about as little Pac-Mans that go around and eat up all the testosterone in your bloodstream. So the higher your SHBG, the lower your testosterone is going to be. One little trick that, that Anna, has actually taught me a little bit about, and it's been on the market not that long, is a birth control pill called Nextelus, which actually has a different kind of estrogen in it. It's a naturally occurring estrogen called estetrol, which does not raise SHBG, which won't, it will lower libido maybe a little bit because you are going to shut down your ovarian testosterone production. Your adrenals should compensate, and therefore it shouldn't impact libido as much as a typical combined oral contraceptive. And listen, in a patient who is not at risk of getting pregnant and really has done all the other things to make herself feel better and her libido still isn't there, she's somebody who would be potentially a candidate for testosterone replacement therapy, which is obviously not something we do at Elektra Health, but is something that a lot of patients ask about, and is for hypoactive sexual desire disorder, which is a whole other talk, something that we could consider. So if that's something you guys want to hear more about in the future, you let me know. Like this stuff is for you guys. So just, so everyone knows, we'll send out a survey afterwards. We couldn't possibly get to all the comments, but I will read all of them. And if there's anything you guys are dying to learn more about in particular, specific stuff, like please let us know, because we are here to give you guys, the education that you probably didn't get in school, right? And that's stuff that we see and we do pretty much every day. So with that said, I kind of wanted to just recap and say that Elektra Health, we are a digital health company. We do a little bit of telemedicine, but really our goal, in being in the world as a women's health program, is to really educate, empower, provide a sense of community, provide women with coaching. We have a menopause coaching program that's RN led. You can think of our menopause coaches as kind of like doulas, right? Menopause doulas that are part accountability partner, part champion, part cheerleader. And we have a platform where we incorporate all these things and stitch them together in a way that really complements the care that you guys are providing in the office. So we are really looking to partner with clinicians who are interested in menopause, who, if you think about it, like you could tell your patients all these things and educate them, and they might say, yes, Jenny, I hear you, and I'm going to go do all those things. Well, guess what? They go back home, they go back into their real world, and they don't do any of those things because that's life. So we really want to take the good care that's being given in the office and make it continuous and bring it home with the patient. And I think that's something that's been missing in traditional medicine. And it's a problem that Elektra is really trying to solve, where education, empowerment, community, access to experts, like Anna, who really know menopause inside and out and can really meet the patient where they are. So for you guys who are on this call are super lucky, because we are going to be reaching out to you guys, or we would love it if you would actually try to schedule some time with us if you're interested in partnering with us, because we can provide some discounts for your patients towards Elektra services and talk a little bit more about how we can partner with you. And there is absolutely no cost to you guys at all as clinicians. This is just something that, we think your patients would really benefit from. And to be honest, like, you don't have the time. We're clinicians too. We know you don't have the time to educate your patients the way you want to. So let Elektra help you with that. And so if that's something you want to chat through with me on a one-to-one basis, 15 minutes, we can go through what that would look like. So does anyone have any other questions or like burning things you want to know before we go? And did you have a chance to kind of peek through and see if there's anything else that we should, BRCA 1 and 2. Yeah. Surgical menopause is a huge topic. Early perimenopause, women who go into menopause, in their 30s and 20s, sometimes like that's a whole different subset of needs that we really, to be honest, aren't meeting at all. And research for this is something we need more of for sure. So
yeah, I will say that for BRCA 1 and 2 patients who themselves do not have breast cancer and just are undergoing a BSO, hormone therapy for them is not associated with increased risk of cancer. So if you are dealing with a woman who's 40 or 45, if she has no other contraindications, like we would prescribe hormone therapy for her. What else do we have it? Yeah, we will check progesterone level if someone presents with estrogen dominant symptoms. We do it day 21. Day 21 is kind of, a fill-in name for secretory phase. So you try to aim for about a week before their planned period to see what that progesterone production is. Knowing that hormone levels also change every day. So this is really a ballpark. It's sort of getting a feel for where someone is rather than diagnosing them necessarily with perimenopause. I do think that it's important to acknowledge when the tests are done in a cycle, because those levels can change so rapidly in a cycle. So I do think it makes sense to do them either on day 3 as a baseline, just like all the fertility people do, or to assess progesterone on around day 21 or about 7 days before the anticipated period. Oh my gosh, I could talk about it all night.
Yeah, I mean, so for those who are asking, this will be, we're going to send an email out either tomorrow or Friday. It will have this recording in it. And it will have, a survey about, how did we do? What can we do better? But also, what do you guys want to know more about? So I really, really want, I'm pleading, please tell us what we should do next. We're hoping to do this at least once a month. If we get a good response, maybe more, but for now, we're going to start with once a month. But again, like if there are things, questions, interest in partnering with Elektra Health, there will be a link in that same email for time to schedule with me to talk through all that stuff. So this was awesome. Thank you guys so much for being part of sort of our inaugural Elektra Health Salon. I'm so energized by, the response to this and by all of your comments, and thank you guys for participating. I know it's not easy. It's Wednesday. But as this evolves, I really hope to see the same faces here. I have my tea, but like feel free to bring your whatever, suits you on a Wednesday night, like, and
that
just
wine.
hang and
that glass of wine
that we're supposed to have, right? Like this is a comfortable, safe place to ask any question. There's no silly question, and we'll be bringing on some really awesome experts going forward too. So that's it. Thank you, everyone. Thank you, Anna. And I hope to see you guys next time. Good night.
Good night.